All right, we'll get started. Good evening, everyone. My name is Alfy Olufade. Welcome to the National Fellow Online Lecture Series. This is sponsored by American Medical Society Online Fellow Educational Subcommittee, the Educational Committee, as well as the Fellowship Committee. Just a quick shout out for the next Fellow Online Lecture Series coming up in 2 weeks, January 31st, same time. It's going to be on CAQ Review. The speaker is going to be Dr. Nathan Cardoz, and the moderator is going to be Dr. Lee Mancini. The topic for today is going to be acute traumatic shoulder pain, and Dr. Jason Zaremski will be the speaker. Before we get started, just some typical statements, understanding that this serves as adjuncts to the individual program's didactics. This is to give the fellows direct access to other educational experts that are AMSSM members, as well as other invited guests, as well as to assist in the CAQ examination preparation. Speaking of that, please remember to kind of log in or watch the CAQ exam review that's going to take on or go on in a couple of weeks from there. A couple of housekeeping rules as usual. Please mute your microphone and turn your video off. As a moderator, I will be going over some of the questions with Dr. Zaremski at the end of the talk. Please send your questions and put that in the chat box, and I'll be able to fill that after the talk is completed. More importantly, and also important, please remember to fill out the evaluation form. It gives us some feedbacks in terms of what we could do better, what we could do differently. So before I get started, I would like to give a quick introduction about Dr. Jason Zaremski. Jason and I finished residency about the same time. He's been a good friend of mine. He's been a very strong ally for trying to help people in leadership roles, and good guy, and a very fine physician as well. He's a non-operative musculoskeletal and sports medicine physician and a clinical associate professor at University of Florida, Department of Physical Medicine and Rehabilitation. Its accolades and publications and leadership roles, if we get started now, we probably won't finish up by the time his lecture is done. So Dr. Zaremski, thank you very much for joining us today, and looking forward to our awesome talk and presentation.
So thank you, Dr. Olufade. So as Alfy mentioned, Alfy and I went into fellowship together. He just did an extra fellowship, so he's a little extra smart. So he did 2 fellowships, but this is really awesome to be able to do this. This is, I think it's the 4th year of this series that was started as a result of COVID. So I will do my best to take y'all through this. Let me bring this up here. Okay. So, Alfy, can you hear me?
Yes, I can.
Okay. All right. So, the topic came up of, can we do something with regards to shoulder pain, but do it a little bit differently? And so what I thought of, and I talked about with Dr. Olufade, is maybe a couple cases of acute atraumatic shoulder pain. It's stuff that you are going to see. I know at least one of our fellows from UF is on, and he's seen a couple of these cases with me. So this is something that not only will be very board heavy. These are definitely types of questions you have to be aware of for your CAQ. It's also going to be something that you're going to see in your clinic. So with that, I have no relationships to disclose. So the first case, and all these cases are actually real. I did not make these up. This is a 77-year-old male with acute on chronic atraumatic shoulder pain. So, sorry, that should have said 76 versus the 77, but 76-year-old right-hand dominant presents with right shoulder pain for a couple of weeks, but also notes that had pain since he was a kid. The pain is kind of continuous, sharp, achy, this crunching feeling. It's in the posterior medial shoulder, so kind of in that rhomboid upper trap, scapular region. Denies any numbness, tingling into the shoulder. Does note a history of headaches and some neck pain that began around a few months ago. Relieving factors is stretching. Has done a few sessions of physical therapy, and rest makes it better. Exacerbating factors, basically any movement, in particular forward flexion and abduction, and pain is kind of a 0 to a 6. 0 is when he's not moving his shoulder. So on inspection, there's no deformity, no defects, no discoloration. There's a little tenderness at the rotator cuff footprint. On range of motion, there is a little bit of increased tone and a little bit of decreased active range of motion. So as we know, full range of motion actively is approximately 170 in abduction and forward flexion. External rotation should be a little closer to 40 or 50 ideally. And so this person is a little bit tight in all directions with what felt like increased tone. Internal rotation at hip level was to the hip pocket, so again, probably a little bit tight. There's also pain with all resistive shoulder motions. And in comparison, the left shoulder, there's full active range of motion in all directions. Strength, pain with external rotation, but there was full strength. And neurological exam was full. There was no obvious vascular deficits. So at this point, I got some x-rays. And these aren't all the views. There also is an axillary view. So you want to make sure you have at least two planes always when you're getting at least preliminary imaging, because if you only have one plane, you're not really seeing the whole picture. And just looking at the AP and internal views, you can definitely see there's a little regularity along the deltoid tuberosity. It looks like there's probably a little narrowing of the AC joint, maybe a little irregularity off of the greater tuberosity. But for 77, this really doesn't look too bad. So based on that, my initial thoughts and what was highest up in my differential was adhesive capsulitis. There was this sort of atraumatic pain that also began with no inciting event, which we'll talk about a little later. But then also there was increased tone, decreased range of motion actively and passively. So I performed a diagnostic and therapeutic ultrasound-guided glenohumeral intra-articular injection. Injection pain pre versus post decreased about 50%. And that was the lidocaine obviously activating, which means I got it into the right place. So that was good to know. Now, normally, what I do, and I'm convinced someone has a frozen shoulder, I'll do an injection if the patient wishes to proceed with one, begin physical therapy and a home exercise program, then I see folks back in about 8 weeks. In this case, given the patient was 77 years old, had no previous shoulder issues, it really was a little bit of an unusual presentation. So something in my gut said, you know what, let's bring him back a little bit sooner. So I brought him back in 2 weeks. And when he came back, he said the injection really didn't help at all. So the only pain relief he had was while the lidocaine was activated. So that's for an hour or two. So that doesn't really count. He notes his pain is actually probably worsened. And now he's saying it can be upwards of 10 out of 10. And, you know, like I said, the pain is worsening over time. He denies any history of movement disorders, neurological disorders. I really try to dive a little deeper into his past medical history and family history, even though he's 77. He states that he's getting to the point where he can't even hold a cup of coffee and bring it to his head. And again, he doesn't have any known history of any other issues, neurological, no cervical spine issues. I even started asking a couple of rheumatologic questions, such as, you know, are you hot when it's usually cold out? Or are you cold when it's usually hot out? Kind of Raynaud syndrome, nothing like that. So the only new information was, you know, when I took a look at him subjectively, there looked like there might have been a little mild atrophy in that right posterior shoulder, maybe that infraspinatus belly. But honestly, nothing else was really helpful. Cervical spine exam, pretty limited range of motion of the neck in all 6 directions, but sensation was intact. So we got some neck x-rays. And as you can appreciate, particularly on your lateral view, there is a significant amount of arthritis in the cervical spine. Now, that doesn't necessarily explain the restricted range of motion of the shoulder, but now you start to think about, well, is this just refer pain, you know, from cervical pathology as opposed to glenohumeral pathology? So my new differential was I still thought he might have had some adhesive capsulitis, but obviously there's some cervical spine osteoarthritis and DISH. For those of you who don't know what DISH is, it's diffuse idiopathic skeletal hyperostosis. Obviously, in someone this age, chronic rotator cuff insufficiency without a response to a cortisone injection is certainly possible. Is it as simple as myofascial pain that's limited to cervical range of motion on the right side? But the question you need to come back to, so you kind of have to look at this like from a 10,000-foot view, is why did this start all of a sudden 2 months ago without incident? Those neck x-rays tell me that whether it's just arthritis or dish, that's been going on for probably decades, if not years. So 2 months ago doesn't really answer that. Furthermore, an injection did not work at all. So I think more investigation is needed. So we got an MRI, and the MRI showed us what the concern is and why pain is worsening. So you can see there's a large mass, you can see in T1 and T2, I put both views on in a coronal view. And, that's obviously pretty concerning. It's something that did not show up on x-ray. So basically, this is an osseous lesion in the proximal humerus and, leading consideration of metastatic disease and myeloma. So definitely we need to get a hold of orthopedic oncology. It is interesting to note that he had mild thickening and soft tissue edema about the inferior glenohumeral joint. So he actually did have frozen shoulder. So I was right about that, but that wasn't the primary reason for all the symptoms. So to complete the workup, we called ortho-oncology. It was a Friday afternoon, of course. Pretty thorough workup, and unfortunately, there were lucent bone lesions in the right ilium, left ilium, T11, L2, and L3, and there was a pathologic fracture through an osteolytic lesion in his left proximal humerus. He wasn't aware of that because the right humerus was hurting him so bad, in part due to the frozen shoulder. So long story short, one of the learning points is worsening pain without trauma and not improving with a pretty reasonable and evidence-based plan, as well as basic imaging. You really need to start to consider, do we need to get more advanced imaging? Do we need to consider a lab workup to consider a systemic process? So this is a really good learning case. Second case. So we have acute on chronic shoulder pain with atrophy. This is actually a really interesting case that two of our residents have submitted to AMSSM that we hope to present in Baltimore. We'll see when the abstracts come out, hopefully in a couple of weeks. So this is a 46-year-old right-hand dominant female, presents with right shoulder pain for at least 18 months, but also has had right shoulder pain since she was a kid, so similar to the previous patient. Same type of symptom description, same location. Now, the patient denies numbness and tingling in her right shoulder, but we're going to come back to that. She has a history of headaches and neck pain that began about 18 months ago. And everything else is very similar to that other case. So far, she has tried Motrin with no relief. She seems to like diclofenac gel or Voltaren gel. She originally started through the VA, and she has gone to 19 physical therapy visits for her shoulder and says she's around 40% better. She has any bracing, she has any injections. Interestingly, she had a stellate ganglion block to the middle of her neck in 2020 on the right side in 2021 due to headaches when she lived in North Carolina. She now has a history of diabetes. She's not using anticoagulants. So on examination, her active abduction was 140. The contralateral side was 170. Passive abduction, a little short, about 150. Her external rotation was fantastic at 80 degrees. Forward flexion, similar to abduction, was a little bit short. She's about 140 to 150 as opposed to 170. Her internal rotation, again, is very good, mid-thoracic, though on the left side was a little better at upper thoracic. Strength was full and symmetric. Special test, drop test was negative. She had a really painful Hawkins and Neers test. Empty can test was negative. And neurovascular, everything was intact. There was no obvious swelling to the sternum or the right chest. There was no pectoral defects, no pain with straight arm abduction if you're looking for maybe a pectoral defect or pectoral tendon injury. So on imaging, 3-view shoulder x-ray revealed maybe some mild AC narrowing. The patient reported she had a right shoulder MRI in 2022. And she said, I don't have the report or images, but I don't think there were any tears there. So take that for what's worth. So my differential, again, a little bit limited on range of motion, so it could be some adhesive capsulitis. So again, tried a glenohumeral cortisone injection with ultrasound guidance. You can see the needle going in there posterolaterally. 15 minutes post-procedure, unlike the other patient, she only had a very minimal improvement. So the lidocaine's not really helping a whole lot, though her range of motion got a little bit better. I referred to PT with a focus on frozen shoulder and to capsular stretching and follow up in 8 weeks. So the reassessment. The patient was concerned with nerve pain, and after her original 8-week appointment, she canceled. She then scheduled a follow-up with me. She reported, as noted right after the shot, her injection really didn't help her at all. Now she reports she's got nerve pain shooting up and down her right shoulder. The pain radiates into her fingers, and she talks about this sort of tearing, popping sensation around the right side of her neck and right side of her chest, and points to kind of the anterolateral neck. She can't do a push-up. She can't do a lat pull down because it's scaring her too much. So you're starting to think about there's the kinesiophobia concept. She also reports some atrophy around the right side of her neck, her shoulder, and chest the last 6 months. Now, remember, she canceled her 8-week follow-up with me, and she showed up months later. So this is all about 6 months after the fact. On physical exam today, her C-spine, light touch was intact. She had full range of motion. But I'm going to show you a couple interesting pictures. When she rotated her neck to the right, her sternocleidomastoid was significantly atrophied compared to the left. Additionally, when you look at range of motion, the range of motion is not horrible, and her retraction and serratus anterior manual muscle testing was actually quite good. So I don't know if anyone's ever seen an isolated injury that caused atrophy to the sternocleidomastoid, but this is pretty cool. This is from the patient. Patient's given consent. You can see the left SCM versus the right. And again, the bottom picture, left versus the right. It's about 3 times as skinny as the left side. So there's definitely atrophy of that SCM. Additionally, if you look here, you can see the concavity to her kind of that anterior triangle come in towards the right upper trapezius. So at this point, you need to start, broadening differential and start including some neuromuscular issues. So one, did the patient sustain a cranial nerve 11 or spinal accessory nerve injury? Does she have a brachial plexopathy or brachial plexitis, depending on the timing? Is there an intracranial lesion that is causing compression of cranial nerve 11 intracranially? Was there an injury secondary to that stellate ganglion block in 2021, and everything else is just a red herring? So as a result of this, the couple things that I did is I got updated cervical spine and right shoulder x-rays in real time, and they were normal. So I then ordered an EMG to assess for a spinal accessory nerve injury or other neuromuscular reason for the atrophy and dysfunction. And I actually ordered 2 MRIs. I got an MRI of her head as well as her cervical spine. The MRI of her head was non-concerning, and the MRI of the cervical spine was see if there was a space-occupying lesion or other anatomical reason, potentially compressing cranial nerve 11 once it is extracranial. The EMG basically showed that she had evidence of a resolving right upper extremity brachial plexopathy in the posterior cord. For those of you who have not reviewed your brachial plexus in a while, I know it's probably giving you the heebie-jeebies, but it's definitely something you got to remember. There's more than just carpal tunnel. But given the history and this kind of crescendoing of pain and then followed by weakness and then even atrophy, most likely the patient sustained a brachial neuritis or syndrome of Parsonage-Turner. There's a second issue. The denervation in the sternocleidomastoid with atrophy raises the question of a separate and distinct inciting event. So she actually likely has 2 issues going on, which statistically almost never happens, in the same location. So the diagnosis is she definitely had Parsonage-Turner syndrome, and we're going to go through that. PTS you definitely need to know. This is also known as neurologic amyotrophy or brachial neuritis. You can read the prevalence. Really, the data isn't great. It ranges from 1 in 1,000 to 1 to 3 per 100,000. The average age of onset in PTS is around 25 years for people with the hereditary form and 40 years age for the non-hereditary form. Men more than women, and it commonly affects, and here's your pearl, the brachial plexus, and specifically the long thoracic nerve, the suprascapular nerve, your axillary nerve, your AIN, or your phrenic nerve. Typically what happens, you have the sudden episode of extreme pain in the shoulder region, frequently during the night and early morning, and then it spontaneously resolves for a few days or weeks. Then it's followed by significant weakness in one or more muscles that those said nerves innervate. However, some symptoms can overlap. One pearl I want to put on here, and is definitely fair game for the CAQ, is some people with PTS may experience something called Kilo-Nevin syndrome, or it's the inability to make the OK sign. That's the picture I have in the upper right-hand side of the slides. And basically, this is a result of neuropathy from the anterior interosseous nerve, which supplies the FPL, the pronator quadratus, and 2 and 3 of the FDP. So that's definitely fair game. So what are the causes of PTS? There's a very rare hereditary form called from the mutation of septin 9. What is more common is viral. You guys may have heard there's a virus going along the last couple of years. COVID-19, I have seen a couple cases as a result. Then after the fact, folks have developed Parsonage-Turner syndrome. And then genetic. Viral is the one, though, I think is very fair game for the boards. You can also have autoimmune and vascular triggers. But again, the biggest one that I have heard, I shouldn't say biggest, excuse me, the correct term is the most common, I believe, at least in recent years, have been triggering such as from viruses or other infections. So I think that's important to note. Other reasons can also be due to surgeries, strenuous exercise, childbirth, as I mentioned, vaccinations, and even immunotherapy or antibiotic treatment. So the treatment for Parsonage-Turner syndrome, now part of it depends on when you see the patient. If you see a patient within the first couple of months, PO steroids, physical therapy, including TENS or transcutaneous electrical nerve stimulation. And if they're less than 9 months out from developing symptoms, you can give them NSAIDs and monitor every 3 months. Now, chronically, surgery may be considered for tendon transfer or microneurolysis if no signs of recovery greater than 9 months from the initial symptoms. And I put a really nice review on there from 2010. Our patient is actually seeing the plastic surgeon for potential surgery on February 7th down here at UF. She already had her initial appointment because she's more than, if you go back to 2022, she's about, what would that be, 22 months out right now. So very interesting case that she unfortunately got PTS, and she might have had another issue to her SCM, possibly due to that stellate ganglion block, though we can't prove that. So third case, this is one that I think is going to be probably most common if you end up practicing in a musculoskeletal practice. This is a 52-year-old right-hand dominant female that presented with severe shoulder pain for times 4 days. She woke with pain, no swelling, no redness, no warmth, no trauma, no neck pain, no radicular symptoms, no nothing. She tried NSAIDs without improvement, and she denies recent vaccinations. On x-ray, pretty obvious, there's a calcium deposit there. It's a pretty large deposit, but it's there. So she has calcific tendonitis of the shoulder rotator cuff. Now, I will say this. For those of you who have ever seen an acute flare of calcific tendonitis, it looks like someone is septic. They will come in tears. They will sit there rocking back and forth. They will not want you to move their shoulder. They will be rubbing it so much it turns red and warm, even though it's not absolutely red and warm. It's just because the patient's doing that. So if there is a concern that there is possibly a systemic issue, I would never fault anybody for getting a CRP, a sed rate, and a CBC with a differential. I have done that on occasion and brought the patient back 24 to 48 hours later, just to be safe. But if you ever have not seen someone in a flare, just know that it can look like they are septic. So calcific tendonitis, anywhere from about 3 to 20% of patients are asymptomatic. They may come in with some reason their shoulders bother them. You get an x-ray, there's a calcium deposit. It has nothing to do why they're there. So just be aware of that. You also have about a third to just under half of patients whose deposits are inadvertently discovered develop the shoulder pain after the fact. Some complications, decreased range of motion, either during the acute flare or they end up developing frozen shoulder because it hurts so much. Risk factors, and I've seen questions on this, are diabetes and gout are associative. Rotator cuff tears are typically present in about a quarter of patients with calcific tendonitis, which should make sense. Because the reason calcium deposits form is essentially a disorganized way of healing after some injuries occurred, which a lot of times may be a strain or a low-grade partial tear of the rotator cuff. So what's the etiology? So we have degenerative calcification versus reactive calcification. Now, degenerative calcification is the more common, more long-standing historical description of calcific tendonitis. What happens is that degenerative changes of the tendon accumulate with age, leading to a decreased distribution of these blood vessels, and then local oxygenation of the tissue, leading to hypoxemia, leading to tendon necrosis, and eventually calcification. but that theory can't really explain why calcific tendonitis has a peak incidence in patients that are a little bit older or why it's self-limiting. So there's a second etiology explanation, and that's a reactive. And within reactive, it's calcific and resorptive phases. In the calcific phase, you go from pre-calcific to formative, meaning the calcium forms, to sort of rest, and then your body resorbs. So typically, this is what's going to be really important. And the more cases you see, and for any of the fellows on, hopefully you've started to see some of these, is this acute, subacute, or chronic? And there is one, more often not, a common classification scheme. It's a near classification, just like when you say near to the ear for impingement. Four types of calcific tendonitis. There's chemical irritation. There's pain due to increased pressure from the mass itself. There's impingement pain likely due to bursal thickening irritation. So basically, it's almost like a bursitis. And then pain caused by chronic stiffness, such as similar to a frozen shoulder. So the workup, typically you're going to start with radiographs in multiple planes. You may consider ultrasound as well, depending on availability of the machine and how good you are as an operator with the ultrasonography. MRI is not first line, but it can show detail in the type of lesion on T1 and T2 imaging. And if you're concerned about any other mass, like if there's some pathology, if there's an infection, obviously, an MRI is worthwhile to get. This is an image I took from this manuscript here. What the arrow was pointing at is a calcium deposit, but what it picked up was an intraosseous cyst as well that is benign. So that's important to understand. So typically the first line treatment are NSAIDs if there's not a medical contraindication. Some people will say you may consider rest with a sling if needed. I personally do not advise that because of the risk of developing adhesive capsulitis. Second line approach is consider a subacromial cortisone injection. Third line approach will be ultrasound guided barbitage. And also you can ask physical therapy if they have the resources to utilize ultrasound therapy. The frequency and the intensity, I'll let you read there. There's been some thought that doing extracorporeal shockwave therapy may be helpful. And if all conservative management fails after 6 months, then you might want to consult your surgical colleagues. So, and again, this is really a board answer. I realize in life that some of the residents and fellows on here that your faculty, they might jump right to an ultrasound guided barbitage, or they might jump right to a cortisone injection. That is fine. What I'm trying to do is present the very, guidelines that are recommended. But any of those three are reasonable approaches. But if the question asks you, what is the first line approach if nothing has been done before, answer like a regular board question. You start out with PON NSAIDs if there's not a contraindication, and then you move on to second and third options. So frozen shoulder. If you haven't seen it, you're not a sports medicine fellow. I think I see between 2 to 4 cases of frozen shoulder in every clinic I'm in. But essentially, the definition is a very painful restriction of the shoulder caused by inflammation of the connective tissues, the capsule that surrounds and holds together the shoulder joint or the GH joint. Remember, and I ask this to every single resident, every single med student, you have to have restricted active and passive range of motion. They're going to be painful. They can sometimes be a result of arthrofibrosis. It is a self-limiting condition. One thing I did want to highlight, I'm not going to read through all this, but this is a really good manuscript from about 12 years ago, is diabetes is one of the more associative factors, so diabetes type 2. There is also a genetic component because there seems to be an increased risk in twins. If you've had it before in one shoulder, you're at increased risk for getting it in another shoulder. But the key things there are typically what I'm going to ask are, do you have a history of diabetes? Do you have a history of thyroid disease? I've seen that in the literature before. And have you had frozen shoulder in the past on the other side? So those are the 3 big questions I'm always going to ask. You can also see the second to last line, associative, thyroid disease, cerebrovascular disease, heart, autoimmune, and Dupuytren's contracture, Dupuytren's disease. So you have 2 types of adhesive capsulitis. You've got primary and secondary. Primary occurs spontaneously without any specific trauma or inciting event, whereas secondary is observed after a fracture or dislocation or some other form of severe trauma to the joint, which then typically entails you need to keep the shoulder immobilized for a little while. It is a diagnosis of exclusion, so you need to make sure, is there an infection? If there's hardware in there, is this a malposition or malfunction of the hardware? Is there a fracture? Is this good old-fashioned cervical radiculopathy that is impeding someone wanting to move their shoulder, like we were talking about in the second case? In diagnosing clinically, typically shoulder pain comes before a loss of motion. Yeah, so shoulder pain typically comes before a loss of motion typically. External rotation, and this is a pearl. External rotation, and typically I do it at the side, is often the first motion affected on clinical examination. So if you're going to have to choose one physical exam maneuver, and I don't know, you guys probably can't see me because I'm sharing my screen, but if you put your elbows at your side, just above your waist or above the belt line, and externally rotate, if someone has a 50% decrement on their affected side, frozen shoulder should be at the top of your differential unless someone's got a severe glenohumeral arthritis. Typically, painful range of motion or passive range of motion is lost with firm endpoints. Imaging is used throughout other comorbidities. I have used MRI and MRI arthrogram on times for other reasons, but they will show that there's thickening of the capsular and periscapular tissues, and in some cases contracted glenohumeral joint space as well. If you're really good with the ultrasound, obviously you can use sonography to see if there's thickening of the joint capsule itself. And what you're going to look for if there's limited sliding or limited motion of that supraspinatus tendon. So there's different stages. I wrote it out here, and then I have a slide that will show you kind of the columns and rows, depending on what you learn best. But stage 1, typically patients present with shoulder pain, especially at night, though they may have preserved motion. The second stage, that's when the stiffness kicks in. The third stage is this maturation stage. It's typically, profound global loss of range of motion with pain at your extreme ranges of motion. During, this stage or the third stage, you can have some synovitis, but your axillary fold, and the inferior part of the glenohumeral space is pretty much gone due to adhesions. And then stage 4 is your chronic stage. So you have this persistent stiffness, but the pain begins to improve as synovitis improves. And then essentially this is known as the unfreezing stage. This is a nice table that I got from the reference below from a couple of years ago. And the duration of symptoms, I think, is also really important to set expectations with your patients. True frozen shoulder can last up to 2 years. So it's important that you explain that to your patients that they may not be better in 3 to 6 months, especially if they're coming in right at the start. Additionally, you may have a patient come in stage 2 or stage 3, and I see a lot of stage 3 patients where they're basically like, it doesn't hurt at rest, but I can't move my shoulder. And it's been going on for, say, 6 months or 9 months. You're going to have to explain to them this may go on for another year or so. So it's really important you set expectations up front as you're doing a pretty thorough history and physical examination. So what's the treatment? Typically, the goal of treatment for adhesive capsulitis is really to restore the shoulder to a painless and functional joint. Very simple. But there's little evidence to support that physical therapy alone, which we always recommend, helps in the treatment of adhesive capsulitis. It helps in conjunction with other stuff, but not by itself. One thing to note, if someone ever asks, or there's ever a question of what specifically in physical therapy is going to be helpful, posterior glide mobilization techniques, as this can help optimize external range of motion. You can try some NSAIDs. Don't take it like a vitamin because you don't want someone to have get heart disease or get an ulcer. Some people give steroids. There's really no significant improvement beyond 6 weeks, but may help with night pain slightly. And really, one of the mainstays of treatment is this intra-articular cortisone injection. Typically, you're going to have significant improvement in the first 3 to 6 months, maybe not long-term. The other thing to make note of, and I'm not sure if it's going to make it to the boards, and I know this is coming more and more, is the advent of using a suprascapular nerve block and or hydrodilation or a barbotage with or without steroid or abreezement. These are definitely becoming, I don't want to say common, but coming more to the forefront, and particularly patients where you're not sure if they're going to be very compliant with physical therapy. That's where the nerve block may help. So they do a home exercise program. Or if someone has uncontrolled diabetes, maybe a Breesman procedure without steroid. And if all else fails, or they have failed treatment for at least 6 to 12 months, you can always get a surgical referral to consider, does your colleague consider doing a manipulation under anesthesia or a capsulotomy where it's open or arthroscopic? I can tell you the surgeons where I practice at, the shoulder surgeons, are very conservative with respect to frozen shoulder. So we typically are going to try to do at least 6 months of physical therapy, at least 1 to 2 intra-articular injections. Depending who the patient sees, they may or may not get a nerve block. Some patients may get a Breesman procedure as well. So it's a pretty straightforward algorithm. It's just, I think, setting expectations and making an appropriate diagnosis when you see the patient for the first time. This is a really good review. It's only a couple years old. So this came out in 2017. So if you want to take a look at it, and again, slides will be made available. And I think Andy Meyer is going to put on the YouTube channel also. So those were 4 cases that are meant to really show acute atraumatic shoulder pain that are very common in clinic and musculoskeletal clinic and are definitely going to be fair game on the CAQ. And that was about 35 minutes with time for Q&A. So does anybody have any questions, any concerns, anything I missed, or Dr. Olufade, anything else you want to add to it?
Great job, Dr. Zaremski. Please a reminder, if you have any questions, I have 1 or 2 questions that I'll start with, but please put that on the chart and I will read that out to Dr. Zaremski. My first question is in regards to the first case, actually the second case when we discussed maybe getting CPR and SED rate and things like that. I've come across a case where I did an initial glenohumeral injection, maybe the second visit. And after the case was all settled, I maybe regretted doing that glenohumeral injection because this patient ended up having a septic shoulder from an STD. I think it was actually gonorrhea that and he presented like this acute atraumatic shoulder pain. I guess is a question and a comment. One is, from your experience, what are the scenarios where you say, you know what, I'm just not going to do that glenohumeral injection the first visit? I mean, I know it's not always that clear, but I don't know if you had any comments or, some of the things you think on that one.
Well, not to stereotype, but I have a question for you. The individual who had the STI, was the patient a little bit younger than you would expect? Meaning like in their 30s or 20s or even
That is
younger?
correct. That is correct.
So I don't want to say rarely, but anecdotally, most of my frozen shoulders are usually in your 40s or 50s, or you've got arthritis and you're older than that. So if I have someone in their 20s or 30s and they've got a stiff shoulder, I would, and again, this is hindsight, but and I think there's a couple, there's an intern on, one of our residents is on, and one of our fellows is on. I'll jump pretty quickly to an MRI. I've started more and more over the years to maybe get some labs and say, you know what, this has been bothering you for 6 weeks. What's another 48 hours? Let's get the lab work. Let's make sure. I am probably a little more conservative with injections than some of my colleagues. I also have now probably a little bit more experience than some of our non-operative colleagues, at least where I practice. So I like to make pretty sure that I'm not going to make the patient worse. Now, that sometimes means the patient's going to be a little ticked off at me, but I would say, look, I would rather make sure I will give you some oral steroids. I'll give you some NSAIDs, but let's do this. Go to the lab. Usually the lab's open until 3 p.m. or go the next morning. I will call you with the results, even if it's a weekend. But I would rather make sure. Now, if you had that same patient, your patient was 55, and they had some factors, I'd say they're diabetic or they've got arthritis or there's calcium deposit, I probably have done the injection just like you. But if they're in their 20s, I've rarely seen anyone in their 20s with a frozen shoulder unless there was trauma. Like they broke their shoulder, they tore their cuff and then they had trouble with post-op rehab, something you would expect, but not atraumatically. So I will also say this isn't on the CAQ, and there's a few people on here who are attendings or faculty. Your gut gets to be pretty good as you get more in practice. I'm in my 12th year. I think Dr. Alfy is in his 11th year. There's one or two other folks on here. You start to see things. You start to have some more experience. And if something doesn't seem right, take a step back. No one is ever going to fault you for getting more imaging or more lab work just to be safe for 24 to 48 hours, particularly if this has been going on for a month, 2 months, 3 months. So that would be I guess, what I would hope I would do if I was in your position, Al or Dr. Olufade, in that situation.
Yeah, so I had that patient about 4 or 5 years ago, and I definitely did not inject the first day. It was a younger person, probably in the late 20s. I can't remember because it's been so long ago if he had a trauma, but I remembered after some conservative treatment, they did ask for an injection. And it was no, I asked the typical systemic questions. All of them were negative, and he denied any history. Actually, I did ask those direct questions, but sometimes, like Dr. Zaremski said, you just got to go with your guts. If you're not sure, get that MRI a little bit sooner than later. We have a question on the chart for you, Dr. Zaremski. A few persons can tolerate 2 years of adhesive capsulitis. Would you entertain manipulation under anesthesia or capsule release as soon as they're unresponsive to conservative treatments, such as glenohumeral injection and PT?
So Dr. Keller asked this question. So number one, as a non-surgeon, I can't say what a surgeon is going to take the OR or not electively. What I can say is if this person walked into my clinic and they have not moved their shoulder for 2 years, I can tell you with high certainty that our shoulder surgeons are not going to take them right to surgery until they've tried something. So this is where they likely will be in chronic stage 4 and a ultrasound guided injection, assuming that they can tolerate steroid, physical therapy, and a home exercise program, they got to try. They got to try it for at least a couple months because if they've tolerated for 2 years, what's another 3 months? Now, if I see someone and they're 3 months in, 4 months in, 5 months in since symptoms started, and they go through that in 3 months, they're not making any progress. Maybe I get an MRI, make sure I'm not missing anything, and that doesn't show anything other than some wear and tear. Yeah, I might send them over to the shoulder surgeon, but they're still going to be at least 6 to 9 months into, they'd be in the stage 3, maybe stage 4 at that point.
So I think his comment was they actually tried the PT and the injection and they weren't better. So would you just automatically send him to surgery? Since you mentioned that maybe some of
So the timing of it would be a little curious. So if I had someone come in and see me saying, I got a shot someplace else, I did PT someplace else, I'd want to see documentation. Was it actually glenohumeral? Was it with image guidance? Was it subacromial? Now, if it was all that stuff, and they have really like that one of the cases I presented where they went to PT 19 times, okay, then maybe that one in that particular instance, I might say, you know what, let's get that shoulder surgical consult. But if we don't have those details, I don't see that documentation, I might just repeat it myself because if it's going on for 2 years, something else is going on. Because usually you're going to, the synovitis, the unfreezing completes itself. Now you may not get 100% of your active range of motion back, but you should get a good percentage of it back. Again, the other thing is how often is that patient stretching? I will literally go through them, and this is, I've never seen this published, so maybe this would be a good research project, is I will show someone how to use a doorway. How do you walk up and then push forward, grab the doorway, lean back, go this way, go forward, grab it, and go back. So you stretch all 3 areas of the shoulder capsule using a doorway. Because if they said, well, I can't go to PT or I'm too busy at work, I'm like, you're not busy, just too busy to spend 30 seconds times 3-4 times a day using a doorway. So I don't know if that completely answers that, Carrie, but I think the devil's in the details. Now, if a patient has truly tried everything and it's been 2 years, oh yeah, I'm saying to a shoulder surgeon.
So I'll give you a little bit of maybe the Emirate perspective. I have two of my surgical colleagues that are a little bit quicker to do manipulation under anesthesia. They have to believe that there's no strong a study that actually shows that physical therapy helps with frozen shoulder, which is a different conversation that we could have. So I will say most of my patients will still like to try that conservative treatment first, but I've had a handful that just say, you know what, if I do the manipulation of anesthesia, I do 3, 5 days of consecutive therapy, and I might go back to almost doing a lot better within a few weeks. They have to go for that.
Well, the only thing I would say to that is, well, I'd say two things. One is, yeah, PT in isolation may not be successful, but PT combined with some form of injection therapy actually is quite helpful. The second thing is, and I don't know all the studies by heart, is what's the success rate of a manipulation under anesthesia? Yeah, and Dr. Bowers was the other person I knew. I put that slide on just for him, who posted for us, but about doing the breezement, hydrodilation. There he put the capillary distension. Um, but I would just say, what is the success rate of MUA? Because I've had our surgeons say it's not the most successful in the world. So, but again, I'm not the surgeon. My goal is to treat appropriately or know when to get to the surgeon. That, for all of our residents and fellows on here, that's the importance of developing good relationship with your surgical colleagues where you practice.
Please feel free to ask more questions on the chart. I have another comment, I guess, in the comments as well. So barbotage is something that's well done, and a lot of folks do it. But I just want to kind of give a quick take on percutaneous tenotomy, which is a little bit different from barbotage. Myself, Dr. Sussman, and a few other folks came up with a study that was published a few years ago showing that they do have similar efficacy, at least patient satisfaction doing barbotage versus percutaneous tenotomy in the treatment of calcific tendinopathy. So just kind of keep that as another intervention or procedure to consider.
And if you take the board out of this, I know this is a CAQ talk, but we're talking more real life. I have not done this because I wasn't trained to do it, and I have to learn. I know that Dr. Bowers has spoken on this, and he just posted, Dr. Olufade. But I've seen some really good data on doing the suprascapular nerve blocks before you do your injection and then going on the therapy as well. So I'm not as personally experienced with that. I just know reading the literature. But for fellows on this call, as well as watching on the YouTube channel, and for our more senior residents who are hopefully going to be going into a sports fellowship, that is definitely something you should keep an eye on for practice clinically. Are there any other questions? I know we got about 5 or 10 more minutes or so, but I know it's getting a little late on the East Coast, at least for an old fart like me.
You're not that old. If you are, then it's I am, sir.
Well, if there's any other questions, my email is available through AMSSM if you're a member. I sent my slides to Dr. Olufade and to Andy Meyer. If you guys want the slides, you're welcome to them. And hopefully this was helpful for this topic. And this has really been a great service that AMSSM has put on for fellows and for the younger faculty on, or even the senior residents or fellows, know that this was started, like I said, 4 years ago. So this is one of the positive things that's come out of COVID. So I'm really grateful for the opportunity to present to all you guys, and hopefully this was helpful.
Thank you very much, Dr. Zaremski, for the presentation. And remember, the next CAQ is going to be January 31st, which is going to be the CAQ review. I appreciate you guys joining us tonight, and have a good night.